No?
Thank you.
Thank you.
Oh, good afternoon, everyone. It's Tanker Resident Day today, and while every day I thank the residents, I really, and the house staff, my fellows, I really want to take this opportunity to thank you all formally for everything you do. And especially, I know for me, you are the guys that make my job very special. So thank you. Should I start or I do have?
Now you're so emotional, we cannot even just know what the daily is like Ruchi. Yeah. Yeah, if you have a lot of slides, I suggest you.
Yeah, it's a topic which has so much information.
Yeah.
And I try to put in a lot, but I would try to keep on track in the time. I think this is the most important slide, I guess.
Well, it's the one everyone's awake on.
So we will start this talk by the learning objectives, and in this talk, we're gonna describe the pathophysiological mechanisms of obesity and the kidney disease. Last year when I gave the grand rounds, I did talk about this a lot. So we will just kind of recap that. And then we will examine the pharmacology and role of GLP-1 receptor agonists in chronic kidney disease. And then we will review relevant clinical trials and their applicability and the limitations in clinical practice. So as we all know that obesity defined as BMI more than 30 affects 1 in 3 individuals in America. And 40 years ago, this map used to look like all blue, light blue, and this is all orange and red. And we discussed last year that obesity is common among people with CKD, like 1 in 2 individuals with chronic kidney disease have a BMI more than 30, and it's higher prevalence than in general population. And being obese increases the risk of proteinuria by 56% and developing stage 3 CKD by 10% over and above the risk conferred by other risk factors like diabetes and hypertension. And rate of ESRD is 10 times higher in individuals with obesity. We talked about the pathophysiologic mechanisms by which obesity causes chronic kidney disease, biclomeral hyperfiltration, insulin resistance, lipotoxicity, inflammation, and alteration of the intestinal flora. And we talked a little bit about the treatment options, but we focused mostly on lifestyle changes and bariatric surgery, and we found that bariatric surgery is most effective among the two in leading to weight loss, but maintenance of weight loss over the years is difficult. So this is the talk where I'm going to focus on GLP-1 receptor agonist. If you are like me, you would have seen a lot of patients in the last year who come to the clinic who are on GLP-1 receptor analogs now. And this is very different to like a year ago when we saw patients and hardly anyone was on GLP-1 receptor agonist. And this is consistent with the market survey of GLP-1. In less than a year, the usage of GLP-1 receptor agonists increased from 5.5% of total population, which is around 340 million at that time, to 8.3%. So more than 10 million users in 1 year. That is a really exponential growth. And earlier this year, late January, FDA approved Ozempic for diabetic kidney disease. So let's take a deep dive into GLP-1. GLP-1 is produced by intestinal cells. These are called L cells. These are conical cells, and they are present throughout the GIT, but their density increases as we go down, and the highest density is seen in the terminal ileum. And these are the conical cells. They have microvilli, like other intestinal cells, but these microvilli are different because they have chemosensors. And the chemosensors sense the metabolic breakdown products of lipids, carbohydrates, and proteins, and signal the L cells to release the peptides. And there are a lot of peptides, not just GLP-1. There is PYY, it acts the same way as GLP-1. There is GLP-2. There is ghrelin, motilin, GIP, and gastrin as well. Now, these molecules they are released, they act in three different ways. One, they go in the blood and have effect in different organs like endocrine effects. One, they act on the neighboring cells by paracrine effect. And very importantly, they modulate the neuronal function. I had to recap in myself for the intestinal epithelium mucosa anatomy. And if you can see, this is the lumen, and these are the crypts with the intestinal cells, and here are the L cells located in between these cells. This is the mucosa, this is the submucosa, this is the muscularis layer, and this is the serosa. And the nerve fibers and the blood vessels are all the way going into the lamina propria and the mucosa. So when the L cells release these peptides, they are able to easily go into the blood circulation as well as affect the neuronal function. So in summary, GLP-1, when it is released, it goes in the blood and goes to the pancreas with the endocrine effect. It causes the islet cells to release insulin. It also stimulates the vagus nerve by the neuronal mechanisms and activate the area in the hypothalamus and the area postrema, which is called the nucleus tractus solitarius. Here is where the central hypothalamic pathways controlling the energy homeostasis is located, the orexin neurons. The PYY GLP-1 peptides also go through the blood circulation in the area postrema where the blood-brain barrier is the thinnest and is able to act on the hypothalamus from there as well. And the last mechanism is the ileal brake, and we'll talk about that. So it causes the insulin release, it causes energy homeostasis, and it causes ileal brake. What is energy homeostasis? Energy homeostasis is a balance between energy intake and energy expenditure. And energy expenditure is measured by resting metabolic rate. That depends on the body composition, age, weight of the individual. So if at rest, my metabolic rate is 1,000 calories, to remain in balance, I need to eat 1,000 calories. That is energy homeostasis. So normally in the brain, in the hypothalamus, are these neurons called orexin neurons. These orexin neurons, when stimulated, causes behavior such as food seeking, motivation, arousal, and decreased satiation. So when we are hungry, our stomach growls. It produces ghrelin that acts on the orexin neurons, activates them, and we start seeking food. We are motivated, we think about food that interests us, and we are awake. This ghrelin also suppresses the release of leptin from the adipose tissues. When we have eaten our food, ghrelin decreases by stretching of the GI mucosa, leptin increases, and inhibits the orexin neurons to cause the opposite effect. The GLP-1 and PYY peptides work the same way. They also inhibit the orexin neurons and decrease these behaviors. Next, I mentioned the phenomenon of ileal brake. What this causes is when the stomach is full, the nutrients flow into the ileum, activate the L cells, release the GLP-1 and PYY, and by a neuronal feedback inhibition, it causes reduced gastric emptying and motility. And this is important in one of the side effects that we see with GLP-1 receptor agonists. So in essence, the GLP-1 has an incretin effect. When we eat, GLP-1 is released. It causes the pancreatic cells to release insulin. It acts on area postrema and hypothalamus to not make us hungry, not seek out food, and make us sleepy after a heavy lunch or dinner. And also causes increased satiety and decreased gastric motility. Now let's talk a little bit about energy expenditure. This was very interesting. This is a study on if you remember, there was a TV show called Biggest Loser. And they really enrolled in this. They had like 16 patients to begin with, and there was an intense diet and exercise regimen for 30 weeks. And this study actually I was able to enroll 14 out of those 16 patients and follow them up for 6 years. And I looked at the body weight change and the metabolic rate. And they found that these 14 individuals at 30 weeks had lost on average 60 kilos of weight per individual. That was a lot. And at 6 years, those individuals on an average had regained 40 kilos of their weight back, all except one individual. So why did that happen? They looked into a phenomena called metabolic adaptation. So metabolic adaptation is or adaptive thermogenesis is the resting metabolic rate after changes in weight and body composition. So for example, my resting metabolic rate, for example, if I weigh 100 kilos and my resting metabolic rate is 1500 kilocalories, I want to get down to 50 kilos. And I want to get down to 50, my colleague who is 50 kilos in weight, and their metabolic rate is 1000 kilocalories. So when I lose 50 calories, I get down to 50 kilos, 50 kilos, my metabolic rate should be 1000 calories. But that is not true. My metabolic rate actually turns out to be 500 kilocalories. So that is called metabolic adaptation. And this is what they were looking for. And they found that at 30 weeks, individuals on an average lost 60 kilos, their metabolic adaptation was less by 300 kilos of individuals when you compare with the same weight. At 6 years, this had gone down to almost 500 kilocalories. And this metabolic adaptation at 6 years was positively correlated with the weight gain. So this study really showed that it's not just a simple math of energy expenditure equal to energy energy intake.
But I'm so sorry. So the stimulus for this metabolic adaptation is
There is a lot of literature on this, and there are literally a lot of hormones like leptin resistance, ghrelin, adiponectin, the whole milieu of inflammation that causes the release of these hormones and cause metabolic adaptation. But I don't know if anyone knows the exact pathway of how that happens.
So do you think this is like related to evolutionary sort of thing where if you are exercising or if you're exerting more, your body is more, the machine is more trained to conduct the same activity at lower calories, like in terms of evolution.
Training
Yeah,
your body that you don't need so many. It is
that you do the
possible.
same level of activity with lower calories. That's what roughly what you are saying, right? Metabolic adaptation.
Yeah, I mean, I'm saying that the person who gained weight and came down to a particular weight is not the same as the individual who never gained weight. I mean, the metabolic changes that happen during weight gain and weight loss persist even after 6 years of losing weight. And I think that the body has like a reset weight that they would try to go back to. That's what my understanding is. But I don't know if it's as simple as.
And so it tries to get back to
Yeah.
that by decreasing the
Yes.
metabolic rate,
Yes.
to gain the weight, to
Exactly.
get to that set point.
See, everybody has a set point for weight,
And so that set point.
so there's no point of
Yes.
Yeah,
exercising.
and no, exercising is the only way you can lose weight, because you set, if you decrease your intake, you're gonna decrease your metabolic rate.
Right.
So
But I
exercise-
think
But did I see the,
No,
I'm sorry.
I'm saying that the body, everyone has a reset, weight set, limit set, but it changes. So when I am at a high weight, my weight gain is set at 100 kilos, for example. If I lose weight, I want to go back to 100 kilos, but with certain things, activities like exercise, for example, I can reset that weight to a lower level. But
So-
it will take time
I see,
to reset that.
because these guys lost 30 kilos arguably
60,
by,
yeah.
by
30
some exercise also, right?
Yes,
What,
yeah,
restriction?
Restriction and exercise,
exercise.
but it looks like the exercise, I don't know whether the restriction reduced the basal metabolic rate or
Yeah.
exercise reduced the basal metabolic rate, and
Yeah.
is there a
Yeah.
good understanding?
Yeah, no, I don't think so. I
Okay.
think it is very, very interesting, intriguing subject to begin
Just trying to
with.
figure out.
I don't know. Do you know?
Is it not exciting?
Yeah, once I start, I just have to keep doing it, that's all.
Yes.
Fascinating questions, and then the caveat that mice are not humans. I spent quite a few years in the lab studying obesity, heart disease and diabetes. And there are a few interesting phenomena. One of them is called paired feeding. When you take a mouse, regular wild-type mouse, you see the sound of Lex's background, and you measure how much that mouse eats in a day. And then you lay out the same amount of food and give it to DVD mouse that's genetically modified, right? To not have leptin receptors. So these mice are the ones who become diabetic, gain diabetes at of age. And if you give it the same amount of food to that mouse, the mouse gets smaller. But if you take them to the DEXA machine and measure how much adipose weight they have compared to lean mass, they still have more adipose mass compared to lean mass. If you drill the skull and you put the little pump that drips leptin onto the hypothalamus in the DBD mouse, it's not going to work. But if you take OB mouse that doesn't have leptin gene and you do that, right? What happens is the mouse, the lean and adipose mass become equal to the wild-type mouse, right? So there is more, and by the way, in the meantime, speaking of exercise, that DBD mouse that got the same amount of food as the wild-type mouse, just regularly walks around the cage and eats at night. That mouse has much more activity today. Not just night, but through night and day, it runs around the cage looking for food, right? So it has more exercise. Despite that, the ratio between adipose tissue and lean mass is different. It never equals the wild.
So in this study, they did measure the body composition, and the metabolic adaptation was adjusted to the body composition as well. So
Fascinating, right?
Yes.
Very multifactorial.
So I don't know if this is
Yes.
also related to the fat mass and the muscle mass, but it's very intriguing. Fun fact, because we talked about GLP-2 and I was recently on service and I had this patient on the South Tower. GLP-2 is also another hormone released by the L cells, and when it is released, it increases the surface area of reabsorption by making the microvilli taller and wider. And so this is used in patients who have short gut syndrome, where a lot of intestine is taken out and they don't have as much GLP. So there's a new medication called teduglutide, which is a GLP-2 receptor agonist used in short gut syndrome. So I found it interesting. So let's go on GLP-1 metabolism. GLP-1 is actually made from proglucagon, which is a prohormone. And this is undergoes a process called post-translational processing. And in the L cells, there is a proconvertase 1 and 3, and it cleaves the proglucagon into GLP-1 and 2. And in pancreatic alpha cell, there is a proconvertase 2, which cleaves the proglucagon into glucagon. And so, the GLP is actually glucagon-like peptide. So they are made from proglucagon. As soon as the GLP-1 and GLP-2 enter the circulation, within minutes, they are degraded by DPP-4 enzyme, dipeptidase enzyme. And that was the underlying basis of DPP-4 inhibitors like sitagliptin in patients who do diabetic control. Now, when GLP goes to the cells, it acts via GLP-1 receptors, and it is a G protein coupled receptor, and it has adenylate cyclase activity, and that it cleaves ATP to form CEMP, and that is the main mechanism of intracellular signaling. GLP-1 receptor agonists act on the same receptors. The only difference is GLP-1 receptor agonists are longer acting because either the DPP-4 site of action is modified in these molecules, or they are stabilized by addition of another molecule. So I wrote down these names because we know a lot of things like Ozempic, Visions, and Wegovy. What's the difference? Ozempic and Wegovy are both semaglutide, but Wegovy is available in very high dose, like 2.4 milligram. So that's why it's approved for weight loss more than diabetes control. And I wanted to bring your attention to Mounjaro and Zepbound. They are tirzepatide, and they have action not only on GLP-1 receptor, but also GIP, which is one of the other peptides that was released from L cells. So what are some of the adverse effects of GLP-1 receptor agonists, like delayed gastric emptying because of the ileal brake mechanism? And it actually led to modification of anesthesia guidelines for perioperative care for elective procedures. Now they wanted them to stop the GLP-1 receptor agonist a week before the surgery, especially in patients who have risk factors like diabetic gastroparesis. It increases the risk of pancreatitis and pancreatic cancer, but the incidence was very, very low in the trials. And multiple studies reviewing data over 9 years have not substantiated the increased risk of pancreatic cancer. Some retrospective studies have found lower incidence of pancreatic cancer. Increased risk of thyroid medullary cancers is actually something that I think is more real than the others. So it's best to avoid these medications in patients who have personal or family history of like Men's syndrome or medullary carcinoma of thyroid, because it kind of it's proliferative for them. So semaglutide is available as an oral medication, and it is a peptide. So how is it, effective orally? So it was really a medication binder, which is called SNAC, and the development of SNAC that allowed a peptide to be taken orally. And this has opened the doors for a lot of other peptides to be taken orally. For example, insulin, it's not there yet. But this semaglutide is coated by SNAC. As soon as it gets into the stomach, it releases the substances to neutralize the acid, and at the same time, quickly dissolves the lipid bilayer of the gastric mucosal cells. So it prevents injury, degradation of semaglutide by gastric pH. Also increase the absorption very quickly. So it achieves the similar levels of semaglutide as injectable levels. All right. Too much basic science at this point.
I'm gonna ask you to repeat it because
The last one, it's kind of
the whole thing,
okay.
we need to understand it better.
Maybe I should just do a grand round on the obesity.
That'll never end.
There is too much public interest.
There is a monthly publication of journals called Obesity.
Yeah.
So now let's go to some clinical studies, right? And especially trying to focus on chronic kidney disease. Yes. So how much efficacious are GLP-1 receptor agonists in diabetes control and weight loss? And a lot of studies were done, and then I'm presenting this like this is a meta-analysis, which the results are consistent across a lot of other clinical trials. So they reviewed A1C, they are looking at semaglutide studies, 7 milligram and 14 milligram. And 7 milligram semaglutide on an average decreased A1C by around 1, 14 milligram 1.1. So more or less, the A1C will decrease by around 1. Weight loss, 7 milligram, it decreased the weight by around 1.1 kilos over 26 weeks. This is 26 weeks. And 14 milligram is more effective. So higher dose, not more effective in A1C control, but weight loss. So what about longer duration? So this was a study, Pioneer 6, they're looking for cardiovascular safety. And they found that over a period of 62 weeks, so more than a year, A1C difference remained the same around 1 between oral semaglutide and placebo. And weight gain also pretty much stable. So they lost weight by around 3 kilos on an average. And over 62 years, the difference remained the same. So it's effective in the long run as well, at least for 1 year. So what about kidney outcomes? Because a lot of studies were done in the cardiovascular outcomes. This was a study done in 2016. And this was the first study, the LEADER trial, that actually looked at nephropathy and outcomes in a secondary analysis. So they had 4,000 patients in a liraglutide group and 4,000 patients in the placebo group. And they defined nephropathy as new onset of macroalbuminuria, doubling of creatinine, need for RRT. It's weird that all cardiology journals keep saying CRRT. Need for CRRT. And death from renal disease. And it was a follow-up of 3.8 years, and they are the ones who first reported that the nephropathy incidence rate in the liraglutide group was lower than the placebo group, and the hazard ratio was reduced by 20%. They did a subgroup analysis in the post hoc analysis, and they are looking at the GFR less than 60 and more than 60. And they found that the benefit was evident mostly in lower GFRs. So Award 7 was the first trial which actually looked at renal outcomes in 2018. It was a multi-center open label trial in 9 countries, and patients were type 2 diabetics, and they all had kidney disease, stage 3 and beyond 4. Very few patients stage 5. And they all had uncontrolled diabetes, and they were already on maximally tolerated dose of ACE and ARB, and they were all treated with insulin or other anti-hyperglycemic agents. So they took these patients, 190 in each group. They divided into like 3 groups. One is dulaglutide, like Trulicity, 0.75. The other is 1.5, and the third group was glargine. They all are maintained on this group, and the doses were adjusted to maintain the fasting blood glucose 120 to 180. Dulaglutide doses were masked, but insulin doses were not able to be masked because they had to be titrated. The primary outcome was looking at A1C at 26 weeks, and it was a non-inferiority trial. And the secondary outcome was looking at GFR decline in UACR at 52 weeks. So these individuals in all the groups, 50% of them had A1C very high. Their weight was around, BMI was around 32 kilos per meter squared. eGFR again, stage 3A, 3B, and 4, 1/3 patients in each group across board. Their UACR on an average was 230, so not very high, but 40% patients had macroalbuminuria in each group. ACE and ARB were used in more than 90% of patients in each group. So let's look at the outcomes on A1C and weight change. Green is insulin, blue and orange is dulaglutide. Blue is 1.5 milligram and orange is 0.75 milligram. And compared to baseline, all groups were very effective in reducing the A1C. Remember, they were all titrating the insulin to get a fasting blood glucose in a certain range. So they were targeting fasting blood glucose. So it was the only thing that they were able to show that dulaglutide was as effective as insulin in reducing the blood sugars. How much weight change happened over 52 weeks? Again, with patients on insulin, increased weight over a year. Dulaglutide higher dose were more effective in weight loss as compared to the lower dose, and the average weight loss was around 3 kilos. The good thing is they were able to maintain this weight loss as long as they're using GLP-1. What about GFR measured by cystatin C and creatinine? Again, green is insulin, red and blue is dulaglutide. On the y-axis is eGFR, on the x-axis is the time. So cystatin C GFR, you can look at the separation between the two, dulaglutide and the insulin. And insulin on the eGFR decline was very prominent at 26 weeks as well as 52 weeks as compared to dulaglutide. In fact, cystatin C GFR actually increased initially in the first 26 weeks by cystatin C GFR, not so much with the creatinine, indicating so maybe implying some of the weight loss could be fat due to the fat loss as compared to muscle weight loss. The creatinine GFR, same thing, decline in all the 3 groups, but more decline in the insulin group versus the dulaglutide, which was significant. And this difference was maintained at 52 weeks.
So this initial effect on GFR is in contrary to what we see in SGLT2 inhibitor, right? Because in SGLT2 inhibitor, initially GFR drops, which makes us hypothesize decrease intraglomerular pressure, which is good for people. But here, there is no initial decline in eGFR. Is that right?
Yes. In fact, it's a little bit of increase, maybe 0.5 at 26 weeks.
That's a little bit difficult to diagnose.
And on the cystatin C GFR increase, the creatinine GFR did not increase.
Right.
So I'm not sure what to make of it.
Can I suggest a hypothesis?
Yes.
We know that GLP-1 receptor agonists decrease muscle mass in addition to adipose mass. So I think you're getting less creatine production. And so it's masking the effects.
About 25% of the weight is muscle.
But also cystatin C is released from muscle.
But cystatin C is attractive because that's a muscle mass independent.
There was no
That was the
initial
opposite
decline.
though.
This is the opposite, is what I'm saying.
GFR declined by
Incredible.
Cystatin C based GFR did not decline.
It increased.
It increased. That's what I cannot.
Yes.
understand.
It's a little bit.
I don't know if
Well,
it is
in the
Oh,
GLP-1
initially.
receptor,
initial.
because we're removing the adverse effects, or the GLP-1 is having CNS effects, which then decrease inflammation and other adverse damage in the
Some of
kidney.
them we can.
It's really important to, I looked at this about a year ago. There are no GLP-1 receptors in the kidney. All the effect of GLP-1 receptor agonists appear to be indirect in the kidney, so it's completely different from the SGLT2 inhibitors.
Oh, I thought there are GFP. I'll let you speak, I guess.
Yeah,
You have a
actually,
slide on
I have slides on
Okay,
it.
I'll let you
I
speak.
think there was like recent studies that show that
GLP-1 receptor is in the
are there
proximal tubule.
kidneys,
Yeah.
proximal tubules and so on.
Yeah.
But we don't know the full extent of it.
Could this be sorry, go ahead.
I'll just say I looked in 3 publicly available single cell RNA-seq databases, all 3 of which said no GLP-1 receptors in the kidney, in the human kidney.
Okay, well, let's see, so maybe the cystatin CGFR, I don't know why there is an initial increase in cystatin GFR as compared to the creatinine GFR. I thought maybe it has more effect on the fat loss versus the muscle loss.
It's exactly just like these leptin slowly.
Yeah,
That's maybe.
yeah. Yeah,
I think that's-
like you said, there's more effect than just, exercise.
Is it cystatin C total nucleated cell burden?
Yes.
Yeah.
So could it be that the weight loss reduces the total nucleated cell burden? I have no idea, so I'm not going.
Yeah.
So no, it doesn't reduce the amount of variable cell, it just gets smaller.
No, I got it. It just is that there is an increased GFR and I'm not able to explain. So I'm just creating a new hypothesis. Please go ahead.
It is a good, I mean, I don't know how much to look into it. It's just at 26 weeks, just this one study, and it was a minor increase.
Okay.
So,
Right.
so they looked at subgroup analysis in patients who had, and this is the albumin creatinine ratio decline, and they also found that UACR decreased at 52 weeks in patients on insulin and dulaglutide, but the insulin was negligible as compared to dulaglutide, and it was dose-dependent effect, and this effect was more prominent in patients who had macroalbuminuria to begin with. So far we are seeing that eGFR decline, albuminuria decline is all more prominent in patients who have advanced kidney disease as well as macroalbuminuria to begin with. So this is the same trial. They are actually the subgroup analysis based on the albumin level, and they found that the difference between dulaglutide and glargine is more prominent in patients who have macroalbuminuria than if they have no macroalbuminuria, and the same thing with the GFR decline. So award 7 concluded saying the association between dulaglutide and reduced GFR decline was most evident in participants with macroalbuminuria. And in this subgroup, mean GFR decline was only about 10% of what was observed with glargine. So really highly beneficial. Albuminuria decreased in all treatment groups, but dulaglutide led to a substantially greater decrease, and this CR effect was dose-related. And these benefits were over and above the effect seen by ACE and ARB, because 90% of participants were on that. So then in 2024 came the FLOW trial. And why was the FLOW trial needed after the award 7? For one, award 7 was only 1 year study. So we know that the outcomes, the renal outcomes, it takes time for them to develop ESRD stuff and, deaths and all that renal outcomes. So if you want to see the long-term benefits. Award 7 had only 197 individuals in each group, and this had like 1,700. So we needed more patients. And FLOW trial is not like non-inferiority comparison trial to insulin. It doesn't really care about what patients were taking insulin and what were not. So it was, there's no dose titration as part of the protocol. So it really just focused on, as long as you are getting your A1C, like is your kidney function outcomes better. So these patients were also type 2 diabetics with A1C less than 10, and they had advanced chronic kidney disease, more proteinuria than a Ward 7. They were all on ASAR. Use of SGLT2 MRA was permitted, and randomization was stratified based on SGLT2. 15% patients were on SGLT2 in this, and no one was on MRA. And they started with semaglutide 0.25 and able to increase the dose over 8 weeks to 1. Outcomes, again, primary outcomes, same like onset of kidney failure, 50% reduction in GFR, death from kidney-related or cardiovascular causes. Secondary outcomes were eGFR decline, major adverse cardiovascular events, and deaths from any cause. So the patients were pretty much, 1767 patients in each group. A1C was comparable, 7.8. BMI was 31-32, just like a Ward 7. eGFR was 46, as compared to a Ward 7 where it was 37. And flow trial included more patients with GFR more than 60, 20% patients who had GFR more than 60. They had more albuminuria, and 15% patients were in SGLT2. So primary outcome for the renal outcomes, eGFR decline less than 15, RRT, cardiovascular death, kidney-related death. On the x-axis is a percentage of participants. On the y-axis. On the x-axis is a month since randomization. And this inset is the same graph, but the y-axis, the scale is larger. So it just shows the separation well. Placebo and semaglutide, and the hazard ratio was 0.76. So semaglutide over 48 months, 2 years, decreased the odds of developing a primary renal outcome by 25%. eGFR decline, this goes up to 4 years, 3.8 years. The eGFR decline happened with both medications, but with semaglutide, it was much lesser, much lower than with the placebo. And this is weeks since randomization.
Is there NGN?
This is any.
You're correcting NGM now.
So
They were in rush to review.
I was like, what is going on? 17 years. Yeah, 17 years. Evaluation.
Emergency approved.
The difference in annual slope was 1.16 ml per minute. So over 4 years, the eGFR decline was 4 ml per minute more in placebo than in the GLP-1 group.
Sorry, how many of these were on the SGLT2?
15%. So this is death from any cause, and again, the semaglutide reduced the odds by 20% at 4 years. And death from cardiovascular cause, 30% decrease in the incidence of the odds ratio in semaglutide versus placebo at 4 years. The number needed to treat was 20 to prevent one renal outcome in 3 years.
Even if I make a small comment, I'm so sorry, because in your sub one before there, a majority of their outcomes are the 50% decline. So I mean, there is a decent amount of less than 15 GFR,
Yeah.
but the majority are through that. So it becomes the number needed to treat is artificially inflated.
Right.
But good, sorry.
Good. So other results of the flow trial, they looked at 2-year UACR, and it was reduced by 12% in placebo and 40% in the semaglutide group. The loss of kidney function, as indicated by cystatin CGFR, was lower by 3.39 in the semaglutide than in the placebo at week 104. That was 4 years. Mean reduction in body weight was 4 kilograms greater in the semaglutide group. Mean A1C reduction was 0.81 greater in semaglutide. But semaglutide discontinuation was seen in 4.4% patients, all due to GI complaints. So what are the drivers for these reductions in kidney outcome that we are seeing? Is it just the weight loss and glycemic control? Or there is some direct effect of GLP-1 receptor agonists in the kidneys, more or both. So bear with me, it's kind of it was really new and challenging for me to understand the study, but they used an exploratory mediation analysis. Maybe someone here knows more about this than me, to attribute the effect to A1C and other mediators of kidney disease outcome improvement, and was trying to find, like, do they account for 100% of the effect, or there is some that is unaccounted for, like indirect effect. So the way it works and the way it is different from just a normal regression analysis is it estimates a counterfactual probability that if, for example, A1C, if your A1C was similar to one in placebo, would the time to event improve as well? And to what degree? And if it is to the same degree, then mediation effect is 0%. But if it is to a higher degree than can be explained by A1C reduction, then there is a percentage between 0 to 100%. So 0% means no mediation, 100% means complete mediation. And they looked at 2 trials, LEADER and SUSTAIN 6. And they were both cardiovascular trials. And they did the nephrologic outcomes for post-hoc analysis. And they found that in LEADER and SUSTAIN 6, A1C mediated effect was 25%. SBP mediated effect by 9% and 22%. And body weight mediated 9% of the effect. They also looked at several other mediators, but they were not, they were 0%. So they say that this probably just accounted for 25 plus 18, like 45% of the effect. So the rest of the indirect effect, like 55% of the effect, what was that? So that's the thing, that's the question they're trying to raise with this study. And even more, they've looked at subgroup analysis, and they looked at GFR less than 60, and they found no mediation of effect due to A1C, little bit with SBP, but no effect with body weight. So in patients with GFR less than 60, where we see more pronounced effect on kidney outcomes, the effect by A1C, SBP, and body weight is nearly negligible. So the effect attributed to each was negligible in patients with GFR less than 60. So what are the other mediators? So the questions it raises is, does GLP-1 have direct effects on the kidney? Does kidney even have GLP-1 receptors? If so, where? And what does GLP-1 do in the healthy kidneys? And what happens in obese diabetic patients? So this is a study I found where they did a lot of immunohistochemistries in IF studies and PCRs. And like you said, they are present in a lot of animals in a lot of places. But in humans, they found GLP-1 receptors in preglomerular vascular smooth muscle cells, that is the afferent arterioles, in the hilar and intralobular arteries, in JG cells and proximal tubules. They did not find any GLP-1 receptors in glomerular capillary walls and glomerular endothelium in humans. But they did find in proximal tubule and some blood vessels outside of the clots. So they do have GLP receptors, but what are they doing? So this study looked at 12 healthy males, and they did like saline infusions with GLP-1 or placebo was administered following a strict protocol for administration, and they are looking at GFR, renal plasma flow, filtration fractions, sodium clearance, renin, angiotensin, aldosterone. And it was double blinded. And they found that in these patients, in healthy adults who are not obese, the GFR, the relative changes in GFR was the GFR increased a little bit, the plasma flow was not very different. the fractional excretion of lithium increased, but the most profound effect was on the clearance of sodium and fractional excretion of sodium. So it really was really high.
This is within hours? Hours?
It is, a good question.
I think I read this study before.
Yeah,
I think it's within hours. They
yeah,
give infusion and within
yeah,
hours they check.
Exactly, yeah.
Just to see the effect of the.
I think you are right.
Yeah.
So they're looking at sodium excretion, placebo 74, GLP-1 higher with a higher dose, and it was really significant. And they're looking at is this effect mediated by renin-angiotensin and aldosterone system? And they found that their levels were not significantly different between the groups. So it is increasing sodium excretion, but not via the renin-angiotensin and aldosterone system. So now they looked at obese diabetic subjects, and they are doing the same thing, and they're looking at placebo and GLP-1. They're looking at sodium excretion, again, like significantly higher than placebo. And not surprisingly, chloride excretion is also higher, calcium excretion is also higher, but very surprisingly, hydrogen ion excretion is lower. So this study, they hypothesized that this study is actually showing a diminished hydrogen excretion, suggesting a reduction in the sodium hydrogen exchange in the proximal tubules. I see Dr. Wiener.
Was it really 2004 or it was 24?
Yeah, it's 2004.
They have been around for a while.
Yeah. I mean, this is a study in humans. They found there's like direct effect of GLP-1 on the sodium hydrogen exchanger. That's what their theory was. That it is probably inhibiting the sodium hydrogen exchanger, so the sodium experience is increased and the hydrogen ion secretion is decreased. Now, as I understand, it's like an oversimplistic model of explanation. I think they need more studies to confirm this.
This is similar to SGLT2, right? I'm sorry, I'll let you go. I think this is similar to SGLT. SGLT2 inhibition also causes energy free inhibition in the proximal tubule. The same way you give antagonists for GLP-1,
Right.
and there is inhibition of energy 3. That's what they're suggesting. But we're not seeing initial decline in GFR, right? Because the thought is that's all stimulating GG apparatus, causing the feedback and libido feedback and decrease the GFR, that is nephroprotective.
Yeah.
But they're still not able to connect the dots here.
No, I think there is a lot more that we need to understand here.
When you heard lithium and sodium, you were comparing, you were trying to say which part of the field is involved, right?
Right.
Lithium is more proximal and
Right.
sodium is everywhere.
Yeah.
Did they see any difference?
Yeah.
That
In the
which part
lithium,
of the
they had seen increased lithium fractional excretion as well in the normal
much
healthy
less
adult.
apparently.
Much less, right?
So
These are healthy individuals. So it's confusing. In the healthy individual, they didn't look at hydrogen ion excretion. And in the obese individuals, they didn't look at lithium ion excretion. So I don't know. And in a way, the study says they looked at it, but there was no result reported. And I tried to see if it's a supplement, if there's a supplement, but there was no supplementary section. So I really don't know how reliable these studies
That's the
are.
tubular part. The
That's the
vascular
tubular
part, you are
part.
saying that it is the A frame, just like the SGLT2
Yes.
inhibitors, they will do,
Yeah,
the TGF will be activated, right?
yes.
So in that case, then you would have, apart from what Dr. Shah says, that well, you would just expect a little bit of a decline in GFR at the beginning, but not just not. Then at long run, how does that help if it gives you just less blood into the glomerulus, bringing down, because the RAS inhibitors are bringing down the intraglomerular pressure in a very nice way of, but
Yeah.
this one is on the afferent side. How would that long run not be detrimental actually?
That is a good question. I don't know. It's a good question. And I think there are, like SGLT2, they kind of, in the later studies, I will show, and they're looking at diabetic nephropathy in mice in development and reversal of changes in diabetic nephropathy when it's due to the GLP-1. They say that there is an anti-inflammatory mechanism.
I want you to finish it on time. I don't want to keep you, but I always ask you at the end, then the order of medicines would count, right? When you have
Right.
3, 4 medicines
Yeah.
for diabetic kidney
Yeah.
disease, which
Yeah.
one first?
Yes,
And if
exactly.
it doesn't, for some reason I
Yes.
cannot use this, can I use the other one? Or in the other study, they have always been on RAS inhibition, for example.
We're doing the study now with all three of them. RAS, SGLT2 inhibitors and GLP-1 agonists. I guess some basic information that could answer your question as the systemic effects, right? If someone is losing 10 pounds of weight, and the blood pressure goes down, we have less perfusion of the blood marrow. Anyone, just like, we give blood pressure medication, the meter is gonna go down. Hypertension is improved, right? To a minor extent, and then it depends which
But I don't know if the
That's a very
GLP,
simplistic, not because
GLP-1 receptor agonist acting on the afferent arteriole, what is it doing there? I don't know if it is causing vasoconstriction, vasodilatation, if it's just anti-inflammatory effect. Like it's just, what is it doing here? I don't know that.
Innocent bystander.
I know with the TGF effect can explain some of that phenomena as well, so. Are these direct effects on GLP-1 on the arterioles, or are they indirect effects? Like Dr. Rupam said, it's weight loss as well, decreases the glomerular perfusion and blood flow to the glands as well.
They didn't look at the weight loss effect on your mediation
No, so
analysis.
they looked at mediation effect of weight loss.
It
and
wasn't.
It wasn't there.
It's not the weight, it's the claim, right? It's
Yeah,
not the weight.
that was the claim.
No, my apologies. That was a simplistic yes, no
Yes.
weight loss.
Yeah.
The weight loss has a graded effect, so
Yes.
I don't know whether they looked at it or like
Oh,
that.
mean by the gradation, like how much degree of weight loss.
Right, because
They were looking. Sorry, go ahead.
no, I'm worried that in a mediation model, it's how they would have looked at graded effect. So it's a very, very complicated process, and I don't know how they adjusted for that, if they did.
But the blood pressure is the same, A1C is the same, all of them are graded.
Right, so they are subject to what you pick as your categorical variable. You see my point, like the 10%, 5%,
Make it
whatever
yes,
it
no.
is, yeah.
And it was over like the period of the studies, which was 26 to
Yeah,
52 weeks, so that was not like a long.
Yeah.
So it is not great evidence. And I just made up a story here, like, how it went in my mind, but I mean, like, these studies are obviously before the mediation study, so.
This is how they write.
So this is the histopathology, and Dr. Ilkun, please help me out here a little bit with the mice. So there is supposedly the C57BL is a regular lab mice, and there is an Akita mice which have insulin deficient diabetes, but they don't get diabetic nephropathy. So they're looking at these mice and they create a GLP-1 knockout of this mice, and they compare it to the GLP-1 knockout of the wild type mice as well. So if we just look at the wild type mice, this is a normal GLOM PAS, this is the fibronectin, that is a marker for glomerular injury, podocyte density, and GBM. Pretty much in GLP-1 knockout mice also is the same GLOM, same histopathology. But when the mice are insulin deficient, even in and GLP-1 receptor positive, they don't get diabetic nephropathy. Like all of these are comparable to the wild type. But when the GLP-1 knockout mice, which is Akita mice, are developed, they develop diabetic nephropathy. So is GLP-1 receptor, presence of GLP-1 receptors making the mice resistant to getting diabetic nephropathy? I don't know. So now this study, in the same study, they took another mice, which are KKTA mice. Again, these are Akita mice, they are insulin deficient, but they are prone to diabetic nephropathy. So they look at the, just focus on these two. This is the wild type. And this is these mice, which has diabetic nephropathy. And they give liraglutide. And they see that the changes of diabetic nephropathy are reversed. And then they, I was telling you about how GLP-1 receptors work with the adenylate cyclase pathway. So they give 2 inhibitors of adenine cyclase and protein kinase A. And they look at the histopathology again, and the changes of diabetic nephropathy are back. So implicating GLP-1 receptors, GLP-1 has some action in protecting against diabetic nephropathy. And there is emerging evidence for the importance of phosphorylation, like increased protein kinase A activity will cause increase in reactive oxygen species due to their effect on NOx-A1 and NADPH oxidase, which is NOx, NOx. Protein kinase A causes phosphorylation of NOx-A1, which protects it against degradation and formation of reactive oxygen species. So maybe there is some role over there. So in summary, GLP-1 receptor agonists are effective pharmaceuticals for diabetes and weight loss, we know that. They decrease the rate of eGFR decline in patients with chronic kidney disease and diabetes. This effect is more pronounced in individuals with lower GFR and in patients with macroalbuminuria. The effect is a combination of risk factor modification as well as direct effects on the kidney, hopefully. And further investigation is required, I think, to elucidate the mechanisms of GLP-1 direct effects on the kidney that may lead to the development of novel therapeutic options. I had a thank you slide after that, right?
It's quite, of course, you ended in time.
Yes.
So, Dr. Ruchi, back to that question. So now we have 4 groups of medicine, pharmacotherapy for diabetic kidney disease,
Yes.
right? Then the question will come, the order and priority,
Yeah.
right? So what would you think? And you saw that, you mentioned actually, in flow we were 15%, and there was
Yeah.
another actually meta-analysis came out last year. They wanted to see the effect of GLP on those patients who were on or are not on SGLT2 inhibitors.
Right.
They saw it was 10% only. So we are really low with SGLT2 inhibitors, it seems. What would be your thought that if we use them just sequentially, how do you do it priority-wise?
So, so in non-diabetic kidney disease, I think GLP-1 is not approved to be used for now. So I will talk about just the diabetic patients and diabetic kidney disease. And I think that, of course, RAS inhibition and the effect of the SGLT, the control of diabetes and hypertension and risk factor control. With regard to SGLT2 and GLP-1, I really don't know which way to go. I think the additional benefit of GLP-1 is on weight loss that is helpful in so many other ways, not just on kidney disease progression. So I think if there is a choice, and if I have to make a choice, I would go with the GLP-1 first, and then eventually have to start SGLT2 as well. But I mean, I don't think we have to pick one or the other. We can just go
Leave
with
it to
all.
insurance.
Just
leave it to insurance.
And there's this market study that showed nowadays there are a lot of reports of deaths on GLP-1, and a lot of these deaths have been reported by use of compounded GLP-1 receptor agonists. And I think that's been one of the hurdles due to the insurance. If people don't get it through insurance, they go to these compounded pharmacies to get it cheaper. And then the other problem with the GLP-2 is as well is, I mean, there are interesting research patterns that have shown the buying pattern of the Americans in general has changed. And this is affecting how food is stocked in the grocery stores because people are not going to the fast food sections anymore and sweet section anymore, and they are buying more healthy stuff. So that was fascinating to me. But insurance is a big question. Has any of you been prescribing GLP-1 analogs to your patients? And have you really encountered any issues with the insurance?
Insurance is always an issue. But I think the other thing is just to give the patient the proper warning of how to use it properly. And, or else they don't tolerate it and they have to be discontinued. So, and tell them what to expect with the nausea. So.
First thing.